online and in-house. So welcome everybody. Again, welcome online, welcome in the room to our last webinar series from this year. So again, it's always fun to see people here. I also, again, welcome people that are online. And first and foremost, I want to acknowledge that we are gathering here in person on campus at the unceded traditional territories. And again, beautiful place. And from those of you who are online, please acknowledge where you're joining us from. Yes, and again, like as the end of the term advanced, it's always very nice to see the change in the seasons. I personally really enjoy now lots of birds that are coming up, the temperature that is changing, the sun that is coming out. So it's the end of the term. So a lot of people have a lot of reasons, I guess, to celebrate or be happy. And this is actually what we're going to do in part today. Before starting with our program, I just want, again, a reminder or mini reminder of who are the HRI Seminar Series Committee. There's me from Psychology, Annie Duchesne, Kendra Ferber from the Northern Medical Program, Cameron, great students from Health Science, Bree, and Bree was online. Hello, Bree, online, as well as Diana, who's present, who've made this seminar series possible with all its various level of logistics and organization, which if it looks like it goes smoothly, it's a lot because we had Bree and Liana to help us during this entire year. So again, really thank you for your help and support. We also have support that we need to acknowledge from the different contributor from the School of Health Sciences, Nursing, Social Work, the Psychology Program, the Northern Medical Program, and Sun Life Financial. So we definitely thank them for their continued support. So before we again start with our with today's program, it's always nice to look at what's ahead of us. And while the academic year reach an end, there is definitely important events that are upcoming. The first being the HRI actually annual meeting, which will take place April 26th. Every member of the HRI are welcome to attend either virtually or in person. This is a very important event where we discuss actually the past and the future of the Institute. So please do attend if you can. Then we are making a little jump into September. September 21st will be actually the start of the HR seminar series yet again. And then something, if you do have your calendar for the fall semester already up and running, I know some of us already do have, November 7th to 9th, there's a research and quality conference, and this will be held, I believe, here at UNBC.
Yeah,
exactly. So yes, so if you have your calendar up, enter those dates. Oh,
the slides aren't advanced now.
Oh,
we're just gonna fix it.
Oh,
Sorry about that. Do you talk so eloquently?
Oh yeah,
So
yeah,
it should be fine.
of course.
Run it up? Yeah, you should be good.
Perfecto. Talk for sure eloquently. Okay, so now it's really my great pleasure, and I think this is something that has been going for many years now, that the last seminar series of the year is really dedicated to the work that has been done by undergraduate students in the health science program, but that does actually do health research more broadly. So today we have three amazing presentations, and I'm not gonna talk further, and I'm just gonna let the space for the students. So the first students to join us, I believe, is Amy, who's gonna come and talk about impact of COVID-19 pandemic on the psychoactive substance use from a Canadian rural and remote perspective. So please take the stage, and I do believe you have to.
We just need to take down our PowerPoint.
Okay.
And it's they're all on the I believe so. That's just right. Is it able? Are we able?
Okay.
Yeah.
Yeah. Oh no, that's not.
Which was your presentation?
It might have been the one that you guys exited out of, actually.
Okay. Maybe do you want to slide around and show?
Yeah, so it's just HRI presentation on third row, second from the bottom.
And are we able to do it so she can see her resolution now?
Should be able to take a little bit of. Looking around.
Turned it on. I just had to go like where I started the presentation. And then was able to put presenting and stuff, but I wasn't sure.
That's pretty. Right.
Now, what are you seeing online?
That's nice.
Not the zoomed in version one.
Not here though. Thing. This here, sorry. Everyone. No? Okay, should be good. Yeah, should be good.
Okay, hello everyone. My name is Amy Crandall, and my supervisor for this was Dr. Malgorzata Kaminska. And today I want to share my results about the impact of the COVID-19 pandemic on a psychoactive substance use from a Canadian rural and remote perspective. So first, we're going to look at background, significance, objectives, methods, key findings, implications, limitations, and future directions. So background. So two major health emergencies have plagued Canada over the past few years, which is the COVID-19 pandemic and the drug overdose epidemic. Some of you might know as the opioid epidemic. I like to call it the drug overdose epidemic because it's not just opioids. There's benzodiazepines that are being mixed in with those opioids and other stimulants, things like that. So the drug overdose epidemic has worsened during the COVID-19 pandemic, with increased use being reported across all provinces and territories, despite a decrease in the quality and accessibility of psychoactive substances and an increase in substance cost. So why focus on rural and remote communities? For the approximately 20% of Canadians living in rural, remote, and northern communities, the challenges of geographical isolation and availability of limited resources for healthy living are compounded by access to fewer healthcare providers per capita and from their urban counterparts. Healthcare staffing levels and healthcare resources were further limited during the pandemic, and recent findings by Friesen et al. Suggested that the impact of these limitations were even more profoundly felt by opioid drug users, whom of which make up a large portion of the overdose deaths since the beginning of the pandemic. So establishing whether psychoactive drug-related overdoses and deaths have increased during the pandemic in rural and remote Canadian communities, and if so, whether a difference on population characteristics exists, is a vital first step towards quantifying the situation. This information will be useful to rural and remote healthcare professionals to better guide on problematic drug prevention interventions, but also provide an insight into characteristics of those who might be most at risk for future COVID-19 pandemic waves or similar future pandemics. So the objectives, so wanted to determine whether there was an increase in psychoactive drug-related deaths in Canada in rural remote communities during the COVID-19 pandemic compared to urban areas and pre-pandemic levels, and to explore whether, and if so, how population characteristics of psychoactive drug-related deaths may have changed during the COVID-19 pandemic compared to pre-pandemic levels, and also look at those in rural populations compared to urban populations. So results of the literature review. So we found, so the primary goal of the literature review was to identify possible risk factors associated with the increase of drug overdose deaths during the COVID-19 pandemic. Increased social isolation, anxiety, and depression were present during the pandemic. Roderman 2020 found that Canadians with worsened mental health due to the pandemic were significantly more likely to increase substance use. A study by McCain et al. Found similar results when interviewing individuals from an Ontario safe consumption site. Basically where participants indicated an increase in substance use, especially in fentanyl, as a result of the pandemic. Numerous reports have found increased substance use occurring in private settings during the pandemic as well. This is dangerous due to the inability of interventions to occur if a user overdoses. So we can't have naloxone interventions, we just won't find them in time. As well, changes in drug accessibility, supply, and composition have been reported since the start of the pandemic. Accessibility was restricted due to border closures, but individuals were still able to purchase drugs online, with many Americans being found to purchase fentanyl and having it shipped through the US Postal Service from China. Others turned to locally sourced substances that were often diluted or cut with other ingredients like fentanyl and benzodiazepines to lower manufacturing costs. A pattern also exists between the number of drug overdoses occurring in the week following CERB payments, which was the financial aid given by the government of Canada during the pandemic. One incarcerated dealer spoke to researchers about this, citing that he would make 50% more profit in the week following CERB payments than any other time. Overdoses were also dramatically increased during these times. Closures or reduction in hours of healthcare and treatment services drastically lowered the ability for those struggling with substance use to seek help. And policy changes related to opioid agonist therapy and the COVID pandemic may have proven fatal to many individuals. Both the US and Canada implemented guides for healthcare providers to provide methadone in 14 to 28 day packets, when many patients are usually given 1 dose per day. And in the US, they found that methadone overdoses, after substantially decreasing since 2000, actually increased once the pandemic hit and these measures were implemented. Okay, methods. So for the study design, it was a retrospective cross-sectional study utilizing data from the Canadian Vital Statistics Death Database. Basically, this database is an administrative one, compiles all of the information about deaths from each province and territory. So the provinces and territories submit all that data basically to be combined into one big database. All individuals aged 15 plus who died due to a confirmed psychoactive substance overdose in the 10 Canadian provinces between 2000, supposed to say 2000, not 2001, and 2021 made up the sample characteristics. There are limitations to the individuals included in this analysis, unfortunately. Upon initial analysis, it was found that the British Columbia Coroner Service has many open cases dating back to 2018. And the problem with this is, with the Canadian Vital Statistics Death Database, they only have confirmed cases. So everything else is everything that's not confirmed yet. We still have a death record for it, but there's no cause associated with it. It's labeled as an ICD code of R99. So there's really no way of telling what these individuals died of. And I think the difference between that and the numbers that you're seeing online is that the BC Coroner Service has estimates of what probable overdose deaths, but they haven't confirmed any of them yet. So basically, to do with that, I had to cut out anything after 2017 that had to do with BC because the numbers were just grossly under exaggerated. Yeah, and as well, deaths in Saskatchewan were not included in 2000 and 2001 due to the small number of deaths that could compromise individuals' anonymity. And data from Manitoba was also excluded in 2021 due to many being open cases as well. They just hadn't caught up yet. And demographics, so there was 67,810 individuals that made up the sample. 68.4% were male, 31.6% were female. Age, the mean was 44.59 years, with a standard deviation of 14.32. And 54.6 of those who died were single, and 16.3% were married. So defining a psychoactive substance death. So a death caused by psychoactive substance was indicated by a corresponding ICD-10 code. It's not supposed to say 19, sorry. These codes were further condensed into 8 categories derived from the drug recognition expert drug categories. Basically, I use these categories to kind of give a more condensed way, a better way of basically talking about these without talking about each ICD code by themselves. So we have central nervous system depressants make up benzodiazepines, GHB, antidepressants, etc. Central nervous system stimulants, so amphetamines, cocaine, etc. Hallucinogens, like PCP and ketamine. Narcotic analgesics, so opioids. Inhalants like toluene, plastic cement, and paint thinners. Cannabis like cannabinoids and synthetics. And another category was created for other psychoactive substances, which was any drug-related death that did not have enough information to place in these 7 categories. So rurality, as you probably all know, there's numerous definitions for it. For this study, the 2016 remoteness index developed by Statistics Canada was used. The remoteness index assigns a number ranging from 0 to 1, with 0 being very accessible, 1 being very remote. These numbers are provided by linking subdivisions for the travel distance to population centers as well as population size. Groups of remoteness were created based on the manual method proposed by Subetti et al., with values between 0 and 0.15 being classified as very accessible, 0.5 to 0.29 being accessible, 0.29 to 0.39 being not very accessible, so on and so forth. So assess population's characteristics. Unfortunately, these were kind of all the characteristics that I could pull from the death database, just because it is an administrative survey and there was no way of linking anything with it being that new. So we've got sex, age groups, location, marital status, remoteness, the number of substance types consumed that resulted in the death, the DRE cause of death. So basically that's if it was an accidental death, an intentional death, or an undetermined death. DRE method of death, which was talking about the actual type of substance that contributed, injury locality, and death locality. So for data analysis, historical cause-specific mortality rate trends were conducted between 2000 and 2021. Two-tailed chi-square tests of independence and unadjusted odds ratios were also used to compare between before the pandemic and during the pandemic. And percent changes between 3-month periods between 2018 and 2021 were also looked at. So this is a lot to unpack here. The first objective, again, was to determine whether there was an increase in psychoactive drug-related deaths in Canadian rural and remote communities during the COVID-19 pandemic, compared to urban areas and pre-pandemic levels. So cause-specific mortality rates between 2000 and 2021, recorded in this figure. Those who lived in a very accessible area had the lowest mortality rates of all groups until 2018, when those living in remote locations declined from 19.07 per 100,000 individuals to 10.76 per 100,000. Even though death counts were much lower in comparison, those living in very remote locations had the highest mortality rates on numerous occasions throughout in 2001, 2008, 2010, 11, 13, 15, and between 2018 and 2021. Individuals who lived in an accessible location had the highest mortality rates in 2017, but otherwise remain comparable to the other groups. Despite these increases, no significant association was found between pre-COVID-19 and COVID-19 groups for periods and remoteness. We'll talk about that some more. So for objective 2, so deaths considered before the pandemic were deaths between January and December 2019, while those during the COVID-19 pandemic were between April 2020 and March 2021. The second objective was to explore whether, and if so, how population characteristics of psychoactive drug-related deaths may have changed during the pandemic compared to pre-pandemic levels. When some characteristics were compared between these two time periods, interesting trends emerged. Very sorry, this probably looks very confusing and large, but it was basically the only way I could do it to get it condensed. We'll talk about it. So males were significantly more likely than females to die during COVID-19. Those aged 40 and under were also significantly more likely to die during the pandemic compared to those over 40. Legally single individuals were also significantly more likely to die than married. Individuals were also significantly more likely to die of an accidental death during the COVID-19 pandemic than those who died of an intentional one. And individuals who died of a single DRE substance type, so like your narcotic analgesics, your CNS depressants, that sort of thing, they were more likely to, single type were less likely to die than those who had consumed more than one type. So again, that polysubstance factor comes into play. And individuals who were poisoned by narcotic analgesics were significantly more likely to die than those who were poisoned by CNS depressants or stimulants. As well, they were significantly less likely to die in a hospital during COVID-19 than in a private home. So again, we're looking at that seclusion of individuals being locked down and feeling more comfortable using in their homes than in public. So this one's we're going to go through it pretty quickly. So the third objective was to explore whether, and if so, how population characteristics of psychoactive drug-related deaths in rural populations may have changed in comparison to urban. Results were pretty much identical to those in the previous objective for more accessible areas. No significant associations were found between pre-COVID-19 and COVID-19 time periods with respect to age, sex, location, marital status, cause of death, some substance types consumed, locality of injury or locality of death. The only one that ended up having an association was with the substance type, which ended up being where those who consumed narcotic analgesics were much more likely to die than those who had consumed others during the COVID-19 pandemic. But again, no significant difference in odds were found. So there was a significant it was a borderline, so it was 0.05. But then the odds ratios didn't work out. So for rurality, despite the non-significant result found between remoteness and the COVID-19 pandemic, there are certain ideas that can be taken away. The only studied risk factor that was found to be significant in rural communities is that they are more likely to die following an opioid overdose compared to any other drug. Increases in mortality rates in these communities show that the risk factors associated with these rates have not yet been identified. It is hypothesized that further research into health service allocation and services may shed more light into this issue. In addition, is anticipated results will continue to rise in these locations as 13 hospitals in rural BC were closed for approximately 4 months in 2022 due to staff shortages. In addition, emergency departments in the rest of Canada have been suffering, with many that used to be open 24/7 having to close overnight and on weekends. So for provincial trends, Alberta and Saskatchewan have had the highest cause-specific mortality rates. And again, we're not including BC in these rates because I couldn't include them. So the highest percent change, however, in mortality rates occurred in Manitoba. This means that Manitoba was substantially more affected by the pandemic than other provinces, but areas like Alberta and Saskatchewan had higher deaths per 100,000 people. Despite these results, no significant association was found between pre-COVID-19 and COVID-19 time periods when Western Canada, so Alberta, Saskatchewan, and Manitoba, and Eastern Canada, so Ontario, Quebec, and Atlantic provinces, were compared. When looking at the literature from an anecdotal standpoint, it could be argued that British Columbia, Ontario, and Quebec were the most stringent when it came to public health measures and lockdowns, with all three provinces frequently being the first to implement measures. Alberta, Manitoba, and the Atlantic provinces usually lagged, with usually being one of the last to implement measures. If one were to compare public health measures against the number of psychoactive drug-related deaths in each province, highly variable results would occur. For example, Alberta has the highest psychoactive related mortality rates in this study, despite having less stringent public health measures throughout the pandemic. Alternatively, when looking at surveillance data from the BC Coroner Service, that includes open cases, British Columbia had the highest psychoactive related mortality rates in Canada and arguably had the most stringent public health measures. Based on this variability, COVID-19 public health measures are likely not the only reason for these deaths. Regardless of rurality, the study found that being male, being between 30 and 59 years old, and being single were risk factors for an overdose and death during the pandemic. Additionally, individuals were much more likely to die by an accidental overdose in their private homes and due to a mixture of substances rather than one. So this study aids in the quantification of the changes in psychoactive substance-related deaths that occurred during the COVID-19 pandemic and in urban and rural areas. There's little research to date on rural populations in general, so the study provides vital information regarding overdose mortality and potential risk factors that may be associated. The study also gives these groups an idea of the characteristics associated with those who may be more susceptible to drug overdose deaths during future COVID-19 pandemic waves or similar future pandemics. By outlining who's more susceptible to these issues, targeted interventions can be used if similar circumstances were to occur again. Additionally, the study fills multiple research gaps. Occasional provincial efforts have been made to attempt to understand the increase in psychoactive substance-related overdoses, but these efforts differ in database used and report frequency, making it nearly impossible to link these reports to other provinces. This study uses a database that covers all Canadian provinces and territories and uses the same definitions for psychoactive substances and rurality. So limitations, there were quite a few. When you're looking at a cross-sectional design, they always have specific limitations. One is not being able to make a causal inference with these types of studies. Rather, they can only make associations. Prevalence incidence bias is also a possible problem with this study, where any risk factor that results in a specific death will be underrepresented among those with the disease. The use of administrative data has always posed some issues as well, as the data has not been personally gathered. Relying on someone else to collect and organize your data is always a risk. For example, in the Canada Vital Statistics Death Database, provinces and territories submit their results to Statistics Canada for the inclusion in the data set. This means that the data must be accurate when the provinces and territories send the data and when it's inputted by Statistics Canada. ICD-10 codes, using them also presents an additional challenge. Physicians are required to sign off on deaths and input the appropriate ICD codes to describe the death. That being said, physicians may miss specific codes that should be included because they are too busy with other patients, other things. After all, missing important ICD codes only has bearing on researchers attempting to interpret the data and not the physicians themselves who are trying to save the patients that are still with them. Another major limitation, again, was the study having the inability to study mortality rates in British Columbia, who've been frequently tagged as the most affected by the overdose epidemic. And because BC plays such an integral part in this epidemic, the results of this study may have been much different with its input. Unfortunately, due to the large number of open cases in the province since 2018, it may be a while before the situation in BC can be quantified. While limited data has been released by the BC Coroner Service, it is difficult to run any analyses with the presented tables, as these numbers are not presented in a case-by-case format. Additionally, their results are considered preliminary because the deaths are suspected rather than confirmed. Finally, the CVSD did not have a variable for cultural identity, which proves a major limitation when discussing psychoactive substance use and related deaths. Indigenous populations, for example, are at a much higher risk of overdose and death by psychoactive substances than non-Indigenous populations. In BC, the FNHA found that overdose events were 5 times more likely and deaths were 3 times more likely to occur among Indigenous people than non-Indigenous. The Chiefs of Ontario, in conjunction with the Ontario Drug Policy Research Network, found that compared to 2015, death rates for Indigenous individuals living outside of Indigenous communities rose by 350%. Those within communities rose by 29%, and non-Indigenous increased by 126%. Another report found that Indigenous people in Ontario experienced another 132% increase in opioid-related deaths during the COVID-19 pandemic compared to non-Indigenous people. So future directions. So fortunately, the presence of these limitations provides guidance for many future studies. For example, if recent data can be collected from British Columbia, the trends relating to drug overdose epidemic can be examined during the COVID-19 period. This could be used to determine if population characteristics are similar to other provinces or if BC faces specific challenges regarding this. Another study could examine the difference between Indigenous and non-Indigenous psychoactive substance-related deaths to determine risk factors attributed to the specific population. And another study could examine whether there are other issues that have influenced the rise in overdose deaths among rural and remote populations, including health service allocation. Any questions?
That's a very thorough and complete, but I'm very impressed. I'm completely honest, it's quite impressive. So round of questions, maybe online there are some questions, I don't know. At this point, in the house, any question? Yes.
You mentioned how you sort of expand it or think of it instead of the opioid crisis, more of a drug substance crisis. Do you think that could even be expanded further to an increase in addictive behavior in general? And
Yes.
So do you think there's other sources of data you could look at, like, gambling's websites or something like that might give you insight into how addictive behavior has changed over this time?
Yes, definitely. There have been, when I was going through my literature review, there were numerous studies that also looked at alcohol, smoking, and gambling, like you said. So that's definitely another area to look into. Because it was an honors thesis, I tried to condense as much as I could, but that's definitely another thing to look into for sure.
And maybe one other question. Go for it.
Yeah, thank you so much. President was amazing. You did a great job. So I noticed men are more likely to die. So what's the reason? Apart from that, I know women are smarter, but what's the reason really? Is there any scientific things behind it why men go to that direction more than women?
I honestly didn't find anything when I was looking into this. There really have been limited investigations into the whole thing. My guess would probably be that women are more likely to participate in other behaviors than men are. So, for example, they may use specific drugs more than women, that sort of thing. So then their risk increases. That would just be my guess.
Thank you, sir.
Oh, yeah. Okay. One last question. We just making a
It's not a question.
Oh, yes.
So Amy and I worked together on this, and I should probably say that Amy worked on it. And I answered the occasional email. I wanted to say, I'm also very impressed, but more than the work itself, what really impressed me about Amy and this year-long adventure is the growth I saw in her. So it started off with questions of what should I do? And very, very quickly turned into her presenting me with options of what she thought the right things to do would be. And then a step further was her telling me which option she would choose and why. So pretty much by maybe halfway through, if not earlier, it felt more like talking to a colleague than anything else. I do want to say we spent about 3-4 weeks chasing down this BC story because we couldn't figure out why the data was missing. And with BC being such a huge province in terms of numbers for overdoses, we really wanted to get it done. And if any of you are thinking, okay, so we're 5 years behind, it's clearly a lower mainland issue. No, we have open cases here in the north that date back to 2018. So it's a province-wide issue. And one of the issues is because we don't actually have, as we discovered, because we went down the rabbit hole, as all good researchers do, we don't have physicians as coroners. We have very limited number of physicians. So when a medical examination needs to be done, you have to wait till the next medical coroner is available. The other coroners do not have that training.
This is really well. Thank you for sharing. Also, and again, I think that this is kind of from a research perspective, a bit of a success story, because I guess when you have a students taking on a research project, you want to see this happening, like just the growth of like the interest, the ambition, the enthusiasm, the autonomy, and then again, the collegiality. Also, I think what's very interesting is that when you go down those rabbit holes, you realize that you just scratch the surface, and then like there's a lot more questions. So there's questions about how the data are being acquired and what the data tells you. And I think this is it. Anybody works with data, this is always the two-pronged stories that we need to investigate. So I guess you really got like a tour de force in terms of the training environment and also maybe future research ahead of you. So congrats, really. Okay, so maybe maybe what we can do, because I would like to have everybody enough time to do their presentation, and we can maybe come back to those questions afterwards if there's sometimes. What about this? Does sound like a plan?
Yep.
Yeah. Okay, thank you very much. Now we're gonna move to the next presenter. And who is this next presenter? Okay. Oh, Jake, perfect. So do you know where your slides are?
Yes, should be on the
They're all on
desktop.
the desktop.
Or just click stop
Just-
sharing.
I think you can actually,
Tried to escape it, but I'm not sure if it did it.
there you go. Move like that. There you go. And then,
And I don't need presenter.
yeah, we can just literally go straight.
Yeah,
there.
you'll need to share again.
Oh, no, it's share. It is share. Yeah, please. I
Click
think,
on click this and then click.
I mean,
There we go.
Yeah.
Okay,
perfect.
okay.
Sorry. Take it away.
How do I make it change on here too? Like when I advance the slides, it always changes up there. Oh, there we go.
It's
There we
changing.
go.
It's
Yeah. This is what they're seeing online,
Okay, perfect.
Okay.
Okay.
not except without the chats.
Okay, hi everyone. My name is Jake. I'm a fourth year Bachelor of Health Science student, and my supervisor is Dr. Sarah Gray. And today I'm presenting my honors thesis, the targeted delivery of Rosiglitazone to adipose tissue for the treatment of obesity-induced type 2 diabetes. So I wanted to start off with the definition of obesity from the World Health Organization. So they state that obesity and overweight are defined as abnormal or excessive fat accumulation that presents a risk to health. And so I really want to communicate the idea that it's not just the accumulation of adipose tissue in obesity that leads to health risks, but it's the dysfunction of that adipose tissue that causes the adverse effects of obesity. So obesity occurs during prolonged periods of positive energy balance, where energy intake exceeds energy expenditure, and this leads to an excess of nutrients being stored in the body, primarily in adipose tissue. And so this leads to excess adipose tissue and a deterioration in the function of that adipose tissue. And so obesity leads to a number of adverse health conditions, such as hypertension and diabetes. And so this leads us to investigate interventions to mitigate the effects of the disease on people who experience it. So adipose tissue plays a very important functional role in maintaining whole body energy homeostasis. There's numerous types of depots of adipose tissue. Subcutaneous adipose tissue lies just below the skin, and visceral adipose tissue lies deeper in the body surrounding your internal organs. And so in a mouse, a well-studied subcutaneous depot is inguinal white adipose tissue, and a well-studied visceral depot is gonadal white adipose tissue. Now, adipose tissue stores and releases nutrients in response to the body's energetic needs, but it also is an endocrine organ. And so it secretes hormones that act peripherally on other tissues to regulate things like hunger and glucose metabolism. And so because adipose tissue plays this sort of diverse role in maintaining the energy maintenance in the whole body, it is an emerging therapeutic target for interventions to treat diseases like diabetes. Now, during obesity, as I mentioned earlier, adipose tissue becomes dysfunctional. So as you're trying to accommodate this excess nutrients, the adipose tissue expands, and then things like macrophages infiltrate it. We get hypoxia and fibrosis, and overall a dysfunctional sort of status of the adipose tissue. And this dysfunctional adipose tissue is less responsive to insulin. And so this leads then to diseases such as type 2 diabetes and hyperglycemia. And so it's been shown that improving the dysfunction of adipose tissue in obesity can ameliorate insulin resistance. And so there's drugs that can act on adipose tissue to sort of mitigate these effects. One of these drugs is Rosiglitazone. And so Rosiglitazone is from a class of drugs called thiazolidine diones. These are potent insulin sensitizing anti-diabetic drugs. And so Rosiglitazone exerts its effects by binding to a receptor. It's called peroxisome proliferator activated receptor gamma, or PPAR gamma. And this receptor is highly expressed in adipose tissue. So when Rosiglitazone binds to this receptor, it induces the regulation of genes. So it upregulates genes involved in sort of healthy lipid metabolism. It downregulates genes that contribute to adipose tissue dysfunction. It promotes the healthy expansion of adipose tissue, and it promotes the generation of new adipocytes that are sensitive to insulin, and that's called hyperplasia. Now, the way that Rosiglitazone does this, it is lipophilic, so it can pass right through the lipid bilayer of an adipocyte, where it can then enter the nucleus to bind to PPAR gamma, to induce the regulation of what we call PPAR gamma target genes. And then this further leads to improvements in adipose tissue function and health. Now, Rosiglitazone has been shown to be very effective at treating type 2 diabetes. However, when taken systemically, it leads to a number of adverse health conditions. This includes things like congestive heart failure and bone fractures. And so this leads us to wonder if we could target Rosiglitazone directly to adipose tissue to induce the insulin sensitizing effects of the drug without inducing these negative side effects when Rosiglitazone reaches other tissues such as the heart and bone. So one tool that has been used recently for targeting drugs to specific tissues are magnetic nanoparticles. And so we've previously shown that we can bind Rosiglitazone to magnetic nanoparticles and accumulate them in subcutaneous adipose tissue using an implanted magnetic field in a mouse via surgery. So we hypothesize that targeted treatment of Rosiglitazone to adipose tissue will induce metabolic improvements similar to a systemic treatment, but without these negative detrimental side effects on other tissues. This project sort of has two parts. The first part is to assess the therapeutic benefits of using these Rosiglitazone-bound magnetic nanoparticles, and we call them Rosi-MNPs, to target adipose tissue. And the second part is to see if we're getting that decrease in detrimental effects from this Rosiglitazone treatment. So previously on this project, we've shown that Rosiglitazone can be bound and released from magnetic nanoparticles. We then induced obesity in a cohort of mice via high-fat diet feeding, and then split these animals into 5 different control and experimental groups. So our first group received a magnet. So they were an obese group treated with Rosi-MNPs with a magnet. So that's the targeted treatment. We then had a group that was obese with no magnet treated with Rosi-MNPs, an obese group that was treated with systemic Rosiglitazone, an obese group treated with a vehicle, so that's just our obese control, and then a mouse that was, or a group of mice that were fed a chow diet, so they didn't have obesity induced, and that's our lean control. We then assessed insulin sensitivity after 14 days of dosing, and then collected adipose tissue depots at the end of the study. And so for my honors, we then used this adipose tissue to analyze sort of changes, morphological and sort of biochemical changes in the adipose tissue. Now, for my honors, this sort of fits into the first part of the project where we're seeing if we could induce these beneficial effects of Rosiglitazone by targeting it to adipose tissue. And so I had 2 aims for my project, assessing PPAR gamma activity in experimental animals via gene expression and assessment of morphological differences in adipose tissue in response to Rosiglitazone treatment. Now, to complete our first aim, which again is the assessing of PPAR gamma activity via gene expression, we used an approach called quantitative real-time polymerase chain reaction. This essentially just allows us to amplify specific genes to measurable levels so that we can see if we're getting changes in gene expression due to treatments such as with Rosiglitazone. So one important component of qPCR experiments is reference genes. And these are genes that essentially they act as an internal control so that we can normalize our data. Reference genes are housekeeping genes, so they're pretty stable across all groups because they play a role in essential cell functions. And so we use software to determine the stability of reference genes. So in my honors, we found 3 genes to be successful or stable across all groups, RPL19, 18S, and GAPDH. And future directions for this aim are to measure those PPAR gamma target genes to determine if the Rosie MNP targeted treatment is inducing PPAR gamma activity in the adipose tissue. Our second aim was to assess morphological changes in adipose tissue using bright field light microscopy. And this was sort of a qualitative first look at the adipose tissue to see if we could notice any changes. And so our first sort of characteristic we looked at was adipocyte size. So when you compare lean controls to obese controls, you can see that the obese animals have significantly larger adipocytes. And that's because they were fed a high-fat diet, and so they had excess calories to store. And so when they store these calories in their adipocytes, it causes them to expand, and that's why they have much larger adipocytes. In addition to, and that shows us basically that our model of diet-induced obesity was successful. In addition to the sort of changes in adipocyte size, we also looked at changes in macrophage infiltration. So I mentioned a little bit earlier that during dysfunctional adipose tissue in obesity, you might see things like inflammation and macrophage infiltration. And so in our obese group, you can see that we did see macrophage infiltration, specifically in the visceral adipose tissue. And so this was really helpful in informing future experiments that we can do to see if rosiglitazone is inducing changes. So as I mentioned a little bit earlier, rosiglitazone induces hyperplasia, and that's the generation of those new small adipocytes. And so we'll use adipocyte cell counting software to see, get the distribution of small and large adipocytes to see if this rosiglitazone targeted treatment is inducing hyperplasia in the adipose tissue. Additionally, rosiglitazone is known to move adipose tissue from a pro-inflammatory to an anti-inflammatory state. And so we'll assess using immunohistochemistry markers for pro and anti-inflammatory macrophages to see if we are sort of getting this shift from pro-inflammatory to anti-inflammatory adipose tissue. So this work will contribute to determining if we can use Rosie MNPs to induce PPAR gamma activity in adipose tissue to restore the health of adipose tissue in obesity. It will also improve our understanding of adipose tissue as a target for therapeutics to treat metabolic diseases that are generally given systemically. And lastly, I just wanted to say a thank you to my supervisor, Dr. Sarah Gray, and all of the members of my lab for helping me with my experiments and teaching me so much. I really had a great time throughout this process with them. Thank you.
So we have times for a few questions. Yes, go ahead.
So thank you so much. It's amazing to see our undergrad doing such a great, research. It's amazing.
Thank you.
We have to really celebrate all of the good things that you guys are doing. So for magnetic nanoparticles for drug delivery targeted, how did you do that? Because my question is how, because we are working on, drug delivery as well. And I know that's one of the reasons how you do it.
Yeah.
Using the magnet to just drag the things to the point you want.
Yeah, I'll go back to that slide.
Please.
So basically what we do is we coat the particles with a coating. It's called alendronic acid, and that allows rosiglitazone to bind to the magnetic nanoparticle. And so what we do is we basically just suspend rosiglitazone in a solution of water and add like 200 micrograms of magnetic nanoparticles, and then we shake it for 24 hours to let the rosiglitazone absorb. And then we can measure the wavelength, I guess, of the solution that the rosiglitazone was in to see the exact amount of rosiglitazone that was bound to the particles.
So that's for making the drug. How did you deliver?
Oh, to the animal?
Yes.
Oh, yeah. So we did a surgery. So we did surgeries on the animals after we induced obesity. We put a magnet into the, surgically put a magnet into the subcutaneous adipose tissue, that inguinal white adipose tissue. And then we daily dose them subcutaneously with the magnetic nanoparticles.
And how you're going to do it if you're doing the real world?
Yeah,
because that's exactly what you're doing right now. So how are you going to do that one?
Yeah, so I don't necessarily know exactly how that would work in humans yet. because it's hard, like we found some difficulties in scaling up our reactions to deliver larger doses. So I don't know 100% how this might translate to actual dosing experiment, like dosing treatments with humans. Yeah.
Talk more later, but-
Yes, for sure. We can talk more.
Is there a question online? for Jay?
No, I don't see any.
This one over there on camera.
Oh, I'm sorry.
So, I mean, I like your model, but it's a model of, you know, you're feeding fat. So you're gonna have increased obesity, your stores of fat. Are there any other models of diabetes used, and would you expect similar results in those models?
Yeah, so there are other models of inducing things like type 2 diabetes in mice. So one of them is like a high sugar diet, rather than a high fat diet. And so that is really effective at inducing insulin resistance as well. So I think that you would see, because you're still getting that insulin resistance, I think you would see similar results from treating mice that were on a high sugar diet, like in comparison to high fat diet, if that answers your question. Yeah.
Okay, is there any other questions?
I got a silly question for that. How do you know your mice are obese rather than just a little overweight? Like how?
Yeah.
For a press.
So we monitor things like weight gain over time. So we weigh them like every or twice a week or whatever to see increases in weight. We also assess their insulin sensitivity and their their ability to dispose of glucose before we start our experiments. And so that allows us to determine if the mice are experiencing insulin resistance yet in comparison to like a chow lean group.
So you have thresholds and.
Yeah, exactly. Yeah. Yeah, like we usually we'll graph it and you can see significant differences between high fat diet fat animals and chow lean animals in terms of their ability to dispose of glucose and how resistant or sensitive they are to insulin. Yeah, and so usually do that and then we go on to our dosing experiments.
Thank you.
Yeah.
Okay, I think I just have one quick last questions, and actually I think that one of your slides you showed, you did run the experiment. So I guess you're just at the level to actually, you expose the analytical plans you want to do, but I saw cross-section of like all your group, and did I invent that, or I just,
No, yes, so you did see pictures of like, so the adipose tissue picture with all the groups?
then I get this one.
Yes.
So, yeah.
So because we just did a qualitative analysis, I couldn't clearly see any differences in adipocyte size or macrophage infiltration between groups, like depending on if they received the targeted delivery rosiglitazone or not.
I see.
And so that's why we have to do these subsequent experiments to
I see.
quantify
Okay.
these changes in adipocyte size and macrophage infiltration. Yeah.
Wow, that's good. Again, really impressive, very, very impressive work, and very thorough and very comprehensive too. So thank you so much. And if there's time at the end for more questions that comes up, we'll take a little time.
Yeah, for sure.
Okay, now we're gonna.
I need to adjust the camera a little bit for you guys.
Oh. There you go. We're just gonna close this, and I think you're on Chrome, right?
Yeah. So I think I have to. Oh,
It's already shared, so yes. Oh, there you go.
there we go. Cool.
Okay, you're good.
Oh, so yeah, I'm actually on Saturday.
I think I'm just gonna look at the camera. Yes, you're good with the camera. Perfecto. Take it away.
How it moves. Trying to figure out how this moves.
Oh.
Oh, there you go.
Way too far. Okay. All right. Thanks for coming, everyone. So today I'm honored to present my thesis titled Assessing the Health Impacts of Particulate Bound Metals in Downtown Prince George. Oh wow, I mean you need a glass of water. But yeah, assessing the health impacts of particulate bound metals in downtown Prince George, a health indexing study on differential effects of high and low dust days. So I'm Ahmad Jalil, and I'm a Bachelor's of Health Science honors candidate. And my supervisor, Hussein Kazemian, is also was the main partner of this project. So the agenda is just as usual. We'll be going through an introduction, a literary review, the data analysis aspect of my research, the limitations. Then we'll be going to the results, discussion, we'll have a Q&A if we have time, and then the references at the end. So lately, there's been a lot of eyes on particulate matter because of the environmental, health, and climate implications. So these fine particulate lead to long-term effects like chronic bronchitis and lung cancer and heart disease and a bunch of other health outcomes. And also short-term outcomes like inflammation and oxidative stress and altered cardiac function. You can see in the graph here that road dust makes up most of the emissions within particulate matter, especially near ground level. And that's why I choose to focus on my study. So also, given the widespread and significant impacts of PM 2.5, research is essential to better understand the precise mechanisms underlying these health effects and identifying vulnerable populations and developing an effective strategy for reducing exposure and mitigating the consequences of the air pollution. So something that I really want to drive home, that most particulate matter, like the data you get, is not just a microgram per meter cubed, although that's what you're usually given. Because typically particulate matter is just collected in like terms of concentration, either PM 2.5 or PM 10 in the ambient air. So there are a few reasons why most governments and research institutions focus on just the concentration. One being you need a standardized method to be able to compare from one place to another. And the other thing is the cost considerations for any other data you would like to collect. So it's important that you're able to facilitate comparative analysis of data across different regions and time periods, as well for establishing air quality index like the HRI and some others that there are. But it kind of leaves out questions about particulate matter composition, because not all particulate matter are the same. If you put your nose behind the car exhaust, it's not going to be the same if you're just walking outside. So understanding this would be vital for both the source identification and understanding the full impact of it on the environment and health. So obviously, as like any other project, there's always going to be challenges. So some of the challenges that I experienced, firstly, was obtaining a background concentration for both air and soil in the sense, which I'll explain. So establishing accurate baselines is very important for assessing how much contamination there is, because if you don't know how much there was before, you can't really figure out how much there is after. But it turns out that it's harder than you think. So figuring out a representative number for, let's say, a place like Prince George, you can't really just go out and somewhere in the boonies and collect a sample of air and say, hey, if there's not much industrial activity here, it looks good. Because first off, Prince George is like a unique area where downtown Prince George, especially where it's in a bowl and you're not sure what kind of air kind of stays in there for a period of time. And you can't really analyze it anymore because where people are living there, you're not going to bulldoze the city to kind of move there to a sample. So I had to come up with a new solution. So I found that there are reference numbers that have been made from the World Health Organization and the EPA. So I was able to make an amalgamation of the data to create references. But the problem I experienced was that these the reference data, were vaguely distributed under an urban area and a rural area. And as we all know, Prince George doesn't really fit in either if you're just defining it through, it depends on what you're doing. If you're doing concentration of people living, it differs quite vastly. But in the end, I was able to draw an outcome, I was able to draw a conclusion from both of them, which I'll get to later. Now, the second challenge I dealt with was data that was under the instrument's limit of detection. So the limit of detection, if you guys don't know, is the lowest concentration of substance that an instrument can reliably detect. So it's really like the resolution of the instrument. So when data falls below the threshold, it's really hard to assess what the true extent of the contamination and make an informed decision and conclusion, because there are places where they decide to either make the limit, like the number, either they remove the data, they might switch it for the square root of the limit of detection, but I find it very arbitrary on how they decide what they should do. And that's where I kind of figured out some other statistical methods to account for the non-detects. Finally, the last challenge I had was trying to differentiate between periods of high and low dust days. although it's really obvious when you're on the ground level what's a high and low dust day, where you can see the dust in the air, practically figuring out when a day is dusty for the ground level is harder, is more of a challenge. And I was able to implement the on the Plaza 400 building downtown. The BC government does routine air sampling with these standardized machines. I was able to establish a threshold of 65% of an average over a span of 6 months to then determine if air quality was high or low. So this is just a quick map. You all know Prince George, so you would know this map, but we pretty much conducted the study between January 26th and May 9th of 2021 at the tourism building downtown. And it's just that little red dot. Maybe should have made it bigger, but so we kind of conducted the study at with a high level of precision by taking into account the varied, because we varied our collecting period. So between what we considered winter months, between January to March, where it was very much colder, we only sampled every Tuesday and Thursday from 9 a.m. till 9 a.m. the next day, where it gave us a 24-hour sample. Then once the road dust season started, when the snow started melting and things started more aerosolizing, which we called the more summer months, which was between March till May, we collected samples daily from 9:30 a.m. from the first day till 9:30 a.m. the next day. So the study was conducted at a height of roughly 10.5 meters, which is just the height of the tourism building. And this kind of provided us with a unique vantage point. So I'm not sure if any of you know, but the tourism building is located between just a major intersection of a bunch of industrial and other residential pollutions. First, we have all the density of the residential neighborhoods nearby. We have the train station, and not too far away, we also have the direct impact from all the pulp mills and the sawmills much far north. And also, it is right on the Trans-Canada Highway 16 East. So it kind of gave us a very nice vantage point of what we're actually expecting to see. So overall then, my kind of objective for this was to examine the environmental and health impacts of the 10 trace metals of interest, which was just cadmium, cobalt, chromium, copper, iron, nickel, manganese, lead, zinc, and vanadium. It was also to be able to accomplish this, I kind of needed to, as I mentioned before, distinguish and classify days that are high dust and low dust. I needed to assess the contamination factor, a contamination degree, and the enrichment factors for the health metals or the trace metals, and also determine the health quotient, the health hazard, hazard index, and the cancer risk for the trace metals. So moving on to the literature review. As we mentioned before, we kind of identified some key challenges and areas of focus in existing research on environmental pollution. One of the main ones was the limited availability of background data and methods to determine the extent of the pollution already present in the environment. Kind of hampered our ability to accurately quantify and understand the problem. So, and then the next problem we kind of, like in the literature review that we kind of had to figure out was the lack of anthropogenic input. So a lot of the literature that focuses on anthropogenic input was very general in nature, where they do countrywide studies rather than certain areas. And especially in BC, only studies I was able to find was a really old one from 2006 in Vancouver. So nothing relevant to BC or even to much of northern BC where my study was taking place. But we were able to find government standards for establishing a basis instead. So that's kind of where we went with that. And in terms of health indexing, the data, the literature was quite comprehensive in terms of how and data we can compare with from other countries to see kind of where we fell under. So through our extensive research, we were able to determine and identify these key indexes that would be relevant, as I mentioned in my objectives, which were backed by a strong foundation of scientific evidence and provided a reliable and robust framework for understanding the extent of metals, air pollution, allowing us to draw a meaningful conclusion and make informed decisions in addressing this critical issue. So the the indexes of the indices of interest was the contamination factor and degree, the enrichment factor, the health quotient and index, and the cancer risk and total cancer risk. So the first index we decided, the first index is the contamination factor. It's a method for measuring just the amount of metal you have in a medium. It's a quite simple equation where you just take the your concentration that you found with a background, and you just do that for pretty much the days you have or the period you decide on. Now, as we mentioned before, figuring out what that background was the biggest challenge. Is getting a metal concentration was quite easy. But this equation was originally only made for lake sediments by a person named Hackinson in 1980s. But over time, it was adapted to. It was found that it was adaptable to a wide variety of mediums, including atmosphere. And the classification kind of goes down through. If it's less than 1, you have a low contamination factor, and if it's greater than 6, you have a very high contamination factor. Then we get to the contamination degree. So this is also made by Hackinson, and in a sense, it builds off the contamination factor. The contamination degree has 2 equations, which we'll get to in the next slide. Oh, I guess it's here, but we have the contamination degree and the modified contamination degree. We found that the modified contamination degree was more relevant to ours because, as I mentioned before, this was adapted from a lake sediment equation. And that equation kind of kind of expected you to use the original 14 metals, which included things that were not relevant in the air, including iron concentrations. So the modified contamination degree simply adds a 1/n, which lets you kind of choose the amount of metals you'd like to analyze. And also gives you a more finer classification portfolio, which starts with less than, which is if a modified contamination degree is less than 1.5, it's nil to very low, and if it's greater than 32, it's an ultra high degree of contamination. So then we also wanted to figure out how much extra input of there is in the environment. And that's where we came with the enrichment factor. And it's a useful tool to determine the presence and intensity of anthropogenic contaminants in the evaluated medium. So the enrichment factor compares an analyte's relative concentrations in the medium to a reference concentration of the metal, in the soil, or you consider crustal values. So you also need to choose a metal that is stable. We decided on aluminum for this study because we didn't find much anthropogenic input, although we did consider the Kitimat plant on the island, but we didn't find much. From the studies that were produced there, not much was actually inputted into the atmosphere, so it wasn't much of a concern. And given the distance, not something we needed to take into account. And the enrichment factor simply goes from if it's less than one, it's no enrichment. If it's greater than 50, there's an extremely severe amount of enrichment. And now there's also the health quotient, and this kind of assesses the non-carcinogenic risk to humans. From the metals in the particulate matter. And it needs a reference concentration for the inhalation exposure, and then which you divided by the exposure concentration. And it's quite simple. If it's less than 1, there's a negligible hazard. If it's greater than 1, it's a significant hazard. And then you can figure out the overall health, the health hazard, the health quotient feeds into the health index. Which is just the sum of all your metals for that period. So you find out your health risk for a certain site, not just for one metal. And then there's the cancer risk. It's similar. It's pretty much the same equation, but you just need different values for your kind of limit, which is the inhalation unit risk for this. And if it's less than 10 to the -6, it's very low, and if it's greater than 10 to the -1, it's a very high risk of cancer. There's a significant chance of cancer not forming, but a significant chance of carcinogenic effects. So there were limitations in the study that I kind of identified. One being that our research is limited to the heavy metals bound to the particulate matter in the atmosphere. We didn't consider the ones in the soil and water matrices in our analysis. It might not make sense why we'd want to analyze those, but the atmosphere kind of feeds into the soil and water eventually. So it's hard to understand exactly what the overall impact would be. So additionally, our health hazard risk assessment focused on the hazard quotient, the hazard index, cancer risk, which might not account for all the potential health risks associated with the heavy metal exposure. Furthermore, individual susceptibility factors such as age, gender, lifestyle, and pre-existing medical conditions were not considered in my analysis, which may affect the accuracy of our risk assessment. Another limitation is the lack of long-term monitoring, which would allow us to track changes in metal exposure and potentially health effects over time. Lastly, our study did not establish a direct correlation between heavy metal exposure and health effects in our local population, which is an important area for future research. Despite these limitations, our study provides valuable insight into the extent of heavy metal concentration contamination and its potential health effects, which can inform future policy and future research efforts. So regarding the data analysis aspect, we kind of encountered, as I mentioned before, the issue of the limit of detection in our data set. So as I mentioned, the limit of detection is the lowest concentration of a substance that our machines can reliably measure. In our case, the sensor data represented data that fell below the ICP-OES's LOD, or limit of detection. And we were able to find three main methods to deal with sensor data. So there was first the Kaplan-Meier survival curve, the robust regression on order statistics, and the maximum likelihood estimation. In our case, to decide which method we'd go with, we were able to find an EPA recommendations on what to kind of follow. So if you have a sample size greater than 50, you'd pretty much follow the robust regression on order statistics. If it's if it's less than 50, it's always robust regression on order statistics. If it's greater than 50, it would be robust regression on order statistics if you have less than 50% of your data censored. If it's between 50 and 80, it'd be a maximum likelihood estimation. And now these are the results we had. So in terms of the classification, using the Plaza 400 data I mentioned earlier, we found that about March time, we started seeing higher dust days. Although the PM values might look higher on some days, which you'd say, oh, why isn't that high dust? It didn't establish that threshold we previously established. And as you can see, it's mainly a shift to the right, and the intermittent sampling we didn't find much in there for higher dust. So overall, we had 31 classified as low dust and 23 classified as high dust. And we had 3 days which were not classified because the Plaza 400 monitoring site was turned off for some reason. We're not sure why. We asked, but no answer. Overall, from our results, we found that there was a very high contamination for copper and manganese with the rural background, and and vanadium, and for vanadium in an urban background. So it kind of, in a sense, you would be able to withdraw from an urban or rural background that if it's an urban background, you're kind of comparing it to your bigger cities such as Vancouver or Toronto, from what we were able to assert from the data to compare from other main hubs. And with a rural background, you're kind of thinking about when you're not seeing any or nearly very insignificant amount of metals in the air. So you can see that for a rural background, you see a huge jump in the contamination factor, which would be very high. But in a rural background, you only see that vanadium in the high dust days would be considered more than low contamination. And in terms of the health outcomes, we didn't find any significant results except for in terms of the health and modified contamination degree, there wasn't much outcome except for in the rural background where you'd find a very high degree of contamination. But in terms of the health outcomes, there was nothing of significance found. But that should not just be taken on face value because, as I mentioned before, there are limitations to this kind of assessment. In terms of the enrichment factor, you can see that surprisingly, there was more metals during a low dust period than a high dust period. And specifically, you can see that copper concentrations were extremely high regardless of the season, although the low dust days had double the amount. So what did we find? So we found out that overall, Prince George has a low pollution degree compared to other urban settings. However, when compared to a rural setting, the pollution degree ranges from high to very high, which is an important consideration for policymakers and researchers. Interestingly, we observed high amounts of copper in the samples, which may contribute significantly to pollution levels in rural areas. This finding kind of warrants further investigation to identify possible sources of copper contamination and develop targeted strategies for mitigating this pollution. And when focusing on the anthropogenic input, we found that all metals examined showed enrichment. And in our modern day, we have all these amount of metals kind of emitted from different sources, so it's kind of expected. But it was kind of surprising, as I mentioned, to see that low dust days had higher amount of enrichment than higher dust days. This could be attributed to the behavior of urban centers during colder months, such as increased burning of fuels, which is mainly observed during this period. And this findings highlights the importance of considering seasonal variation in human activities when assessing pollution levels. And finally, in terms of the health outcomes, our study found that there was no increased risks for adverse health effects or lifetime cancer risk. The threshold values for hazard quotient, hazard index, and the total cancer risk were not exceeded in our analysis. However, it is important to note the limitations of our risk assessment, such as the influence of individual characteristics on the health risk associated with the heavy metal exposures, and which were not considered in our study. Additionally, the importance of long-term monitoring cannot be overstated, as it would provide a more comprehensive understanding of the potential health risks over time. Our study provides valuable insight into the pollution levels, potential anthropogenic input, and health risks associated with the heavy metals exposure in the area. These findings can inform the future researchers and policymakers at reducing environmental pollution and combating public health risks. Yeah, and that's it.
Oh, yeah, just you're not going to see me. Well, question.
I was gonna do this, but I wasn't sure, so I just. It's really exciting work, and one of the things that we know in Northern BC is that more attention is needed to this issue. So it's great to see this work getting underway. One of the things I was curious about is whether you've thought about audiences that might be interested in hearing about this preliminary work, and there's groups like PG Air and others that are paying close attention to these kinds of things. And I just wondered if this sort of, if you've been thinking of, given that you've done all this work, if you've been thinking about sharing some initial findings with groups like that.
Yeah, now that I finished the work, I just got a contact information from someone at PGR to possibly show this to the council to see if the findings would be of any interest to them, since they're the leading authority in Prince George for most of the policy making. So yeah.
So pretty exciting that your work might be able to inform, and that there's just such a hunger to know more about these issues across the north. So yeah, congrats.
Thank you.
Yes, sir. Yes.
What exactly is road dust? Is it like the components of the road material being broken up, or is it the stuff that's being put down on the road in winter to make them?
So it's actually a combination of both. So first off, in the winter months, especially like let's say on the Trans-Canada Highway, you'll have cars driving over it, and their exhaust will emit into the ice and snow that's compacting into the layer you have. During the melting season, like during the summer, springtime, when all that ice melts, you'll have it aerosolized, and it's already trapped all the 6-ish months of collection of any kind of debris that was there. And then over on top of that, as you mentioned, there's the road components to it, and there's also the things that we threw on top of it, like more gravel, other types of things that were needed for traction. So it's pretty much just an amalgamation of whatever was on the road.
Yeah, Kendra, you had a question, and then yes.
I talked a little bit about this before, but Prince George has a reputation for air quality. It's really here, but this will be quick 2 parts. So for air quality, we're looking at the total amount of particulate matter and then the composition of the particulate matter.
Yeah.
So does Prince George have a higher total amount of particulate matter in the atmosphere compared to urban or rural settings?
And compared to urban and rural settings now, I've looked at data before, like prior to 2015, and it looked much worse. But right now, compared to urban settings, I mainly compared to Vancouver and Toronto. Prince George is doing better than that, and that in particulate matter. But like identification of certain components like trace metals, there's not much being done on that, as I mentioned, because of the cost usually and the time you have to spend to collect those samples.
So my next part of that then, other than the metal contaminants in the particulate matter, is there anything else we should be concerned about, or any potential other factors that could affect health that we should be measuring?
Oh, definitely. So definitely. So I focused on metals because that was the kind of what I was like most interested in, but there's also polycyclic aromatic hydrocarbons, which is a big field in terms of atmospheric health. There's also volatile organic hydrocarbons, which also there's many, like a multitude of components, which are both present in the atmosphere and also in industrial hygiene settings, which are of interest usually. So it's kind of shifting from you're learning about it in indoors, and then you're like, oh wait, we find them outdoors. And so so there are definitely things you should, more than metals and particulate matter, that you should keep in mind.
Right, thank you so much, Ahmad. Thank you, Kendra, because Kendra was the secondary event. She has Ahmad a lot as well. I appreciate that. So because I know that we have undergraduate students here, I think I want to just share Ahmad's, journey, because usually at NAS we hire a couple of students every summer, up to 5 sometimes. So, and then when I have a class, you just, I consider my class as a job interview. And if you are good, then you can just come and work with me. And Ahmad actually came as a volunteer, so working with us, and he really showed lots of interest. And the angle that he's looking at air pollution that we started back in 2016 is very different from other, because I don't have any health background. And thank goodness Ahmad is helping us with that. And so he was very successful. He already published a paper as a co-author. And the second paper is under publication. Of course, we have rejection stuff. He has to deal with those things. And he's working on the third paper as well. So it's amazing for an undergraduate student to this level. And Ahmad was the winner of NCEP USRA this summer, which is great thing. So he's going to stay with us. And if things goes well, hopefully we're going to keep him a little bit longer. So that's something I thought all undergraduates should know, that UNBC really offers those opportunities that usually in bigger universities, most of you cannot find those opportunities. Again, congratulations, you did a great job. Thank you.
Yeah, this is amazing projects, and you can see the range of health research also that has been done by our undergraduate, which really, I think, showcase what are we doing, and to have all of this achievement at the undergraduate level is spectacular. So really kudos to you, and I think that I hope that it inspires people that are at the undergraduate level, either online or either in the room, although I'm like, maybe there's not so many. But yeah, so I feel like we are coming to an end. I just was, because I knew there was some questions for you that were online that were unanswered. And I was just wondering if we could just maybe have those answered, if possible. Yeah. And then for the few minutes that we have left, because there's nothing like, if there are interesting questions that these are unanswered, I just feel like it's a missed opportunity. Yes.
Amy, do you want to come back up so that you're on camera? Okay. So there were 3 questions, and the first was, is there a rationale for why data of the 3 Canadian territories were not included in the original database consulted? Sorry, can you see?
Yes, fine. Okay. All right. So yeah, with the territories, wanted to include that, but honestly, I know with the Canada, with that database, they stopped including data from the Yukon as of 2017. But there was also just a very low number, low enough to the point where it just wasn't, we would be worrying about anonymity. And yeah. Said that right. So they were just cut out of this. It doesn't necessarily mean that there's no deaths that are occurring there. It just, I mean, there's so many with the healthcare system up there, there's so many issues. So it's not impossible that there is definitely more up there that's just not being really documented well. Yeah, it's hard to say.
And then just because the audience, do you want to read it out or do you want me to?
You can read it.
Okay, does the study reflect information whether there were more new drug users during the study time, or will it be appropriate to hypothesize that there was an increase in drug use amongst previous drug users?
Okay, so sorry, just want to make sure I'm answering both parts. Okay, so new drug users versus previous drug users. So I kind of found information to do with both. With my study specifically, we didn't really look at that, it was just mortality rates. But when I looked into the literature review, found that nobody's really talked about whether there's been new drug users. But in terms of previous drug users, they have been, like I said in my presentation at some point, they have been having increases, basically reporting increased use. At one point, I was going to include a Canada perspective survey in the honors project, but again, there was some time constraints there, so I cut that out of this one. But the preliminary results I found there were that a lot of people did increase their use of substances just through that perspective survey. Didn't necessarily, and a few initiated during that time, but I hadn't looked into it quite enough to really get actual numbers with that.
Great. Does BC coroners have a timeline to determine the cause of death for certain individuals? How many months, years can the cases be open?
We have absolutely no idea. We've tried to contact BC Coroner Service, both locally and provincially. I never got responses from either. And that was like almost a year ago. So yeah, there's absolutely no timeline. I've looked at even news articles that have discussed this. There's like, yeah, basically we'll get to it when we get to it. So yeah, that's unfortunate, but it's kind of what we're dealing with.
Could I ask a question?
Yeah, of course.
In terms of your study, were you ever able to like establish whether the drugs were being used recreationally or therapeutically at any study, or is it always assumed that it's recreational use?
Because it is administrative data, there was unfortunately nothing to constitute whether it was recreational or not. I think for the most part, especially with opioids, basically the overdose epidemic kind of started specifically with opioids back in the 90s, where we had overprescriptions occurring, especially with Purdue Pharma. I'm not sure if you've heard about them, but their drug was kind of major news for a long time there, and it was being what's the word I'm looking for? It was being promoted in a way that wasn't legal, accurate, you know? So basically it kind of started around there where it was being used medically, and then people started using it kind of finding more recreational means, but then I think other people kind of jumped on board and just using it recreationally to begin with. So I think now it's more to do with, because people have we've actually implemented some policies that have decreased the prescription of these drugs. I feel like it's probably more recreational use at this point, but again, there was no way to determine that.
That's it. Well,